So, a very good evening to all of the people who have joined with us for this 10th webinar of HORIBA Medical, Heart to Heart with HORIBA. And it has been very much overwhelming that you people always take out time and come and join with us for a new topic with your new queries, questions, or comments and the feedbacks on the same. So, today here we are on this our 10th webinar, which is basically related to the laboratory parameters in an emergency department, and as we have been looking into many more journals articles coming up as in short articles coming from China, Europe, or America, or in say per se from India as well. It will be very much soon been published in many journals, which says the use of CBC and CRP testing together, which is helping in COVID management and monitoring. So how does it actually work? So I just want to put it across like, yes, do we have an 100-day experience of COVID in India? Because this infection started in 2019 December in China, and probably India got affected, or the first cases which were seen in India were in between January and February. And it is almost like, which I remember from post Holi or the Holi festival, we are still sitting at home, and the lockdowns have been getting eased. Sometimes they are getting more often stringent. But yes, we do have 100 days of experience of COVID in India from our healthcare sector. And what are we going to share today? Is it like what is the role of a laboratory parameters, or what is how an emergency department comes into picture, and how do they do the laboratory testing, the timely testing, or the parameters? How do they choose the parameter for particular or specific diseases in emergency? What are the ambulatory testing for monitoring? As of now, we all have been questioning what exactly has to be the test done in the mild cases, moderate cases, or severe cases. We all know in severe cases of ARDS, but yes, there are certain doubtful or suspicious cases which lies in between mildly symptomatic or say moderately symptomatic, and some are asymptomatic as well. Is there any role of CBC or CRP testing? Much more have been written in many of the journals, as I have already mentioned, in Europe, China, or anywhere across the globe. So let's see what is an Indian perspective on this. So moving forward, we have the first topic or the first experience of the emergency medicine department would be shared by Dr. Srikrishnan. Dr. Srikrishnan is a consultant and Department of Emergency Medicine and Critical Care at Amrita Institutes. He is also a training center coordinator for Amrita American Heart Association International Training Center. Is uh, he is an international instructor for Australian Registry of Emergency Medical Technicians. He is also an academic coordinator for Society for Emergency Medicine in India, which is in Kerala zone. Faculty for Kerala Disaster Management Cell, co-editor of Universal Journal of Medicine, co-editor of Eurasian Journal of Emergency Medicine, and he's also been a reviewer of International Journal of Emergency Medicine. So without wasting much of the time, we would like to call upon Dr. Sri Krishnan to share his experiences of an emergency department and how do an emergency department function in coordination with the laboratory services. So can I have Dr. Sri Krishnan online? Very good evening, sir. And I think you can go ahead with your experience and the presentation with the point of care testing or the laboratory services in your emergency department. Your voice is not there, sir. Can you just open up your mic? So can you just switch on, switch off your mic on the screen? Yeah, there's looks to be some technical issue which is coming up from your side, because we can see your video, but your voice is not coming up. So no worries, the audiences across who have joined. There are always some glitches in every part of our life, and internet or technology can be at a problem sometime. So we'll very soon get him on board. Your voice is still not there, sir. Basically, I think your video, you can just put off your mic on and off and see it again. Don't worry, Dr. Sri Krishnan will be back, because sometimes it do happens when your systems gets hanged up somewhere, and when you're
able to hear now?
Yeah. Yes, we can hear you now, and you can start your webcam as well.
Yeah, you're able to hear now? Yeah.
Yes.
Yeah, fine.
Thank you.
Okay.
The stage is all yours, sir.
Yeah,
Go ahead.
fine. Thank you. Good evening, one and all. So maybe the next 15-20 minutes, I'll be just sharing my experience with the POC CBC CRP, which has been we have been using for the last maybe nearing 1.5 years. And I'll just give a brief outline regarding the session, how we'll be going about it. So first of all, many of you will be familiar, but it will be not apt for those people doesn't know what is exactly a point of care testing. Why you need a point of care testing in ED? Maybe in the late 1990s, that's the time when the POC testing started to pop in slowly. We all know that the first one was the glucose random blood sugar. Then slowly now we have developed into up to procalcitonin doing in an emergency department. So that is how it has been developed. And we will also see what are the commonly done point of care testing in the emergency department. Then the most important question, how useful to have a CBC CRP in POCT in ED? That's many emergency department doesn't have a CBC CRP, but I'll share my experience about it and brief outline regarding our micro semi CBC CRP that we have been using for the last 1.5 years. And what are the different clinical scenarios that it will be helpful. And Dr. Dhruv will be sharing regarding his COVID experience. So, and what will be the advantages and disadvantages of a POCT. So that will be my brief objectives. So now the first thing, what exactly is a POCT? So it is defined as any test that is performed patient in a primary or a secondary care area. It can be in the emergency department. It can be outside the hospital also, but not the conventional laboratory setting, except that anything is done that we can call it as a POCT. So it can be a near patient testing. It can be a bedside testing. It can be an extra laboratory testing or decentralized laboratory testing. Anything you can call it as POCT. Now coming to what should be an ideal POCT, we all should be aware that in routine lab investigation, the cost factor is much less as compared to a POCT, because the equipment has come down and it has to be a sophisticated one, and it has to, you need to move around and mobility, all those things come. So the most important thing is that it should be an affordable and for those at the risk of infection. So already they are spending a lot for this group of patients. They have to send their all the antibiotic, blood culture investigations, all those stuffs, ICU charges. And when you're doing it, it should be affordable for the patient. That should be the most important thing. And the most question arises is the sensitivity. How good is it from the laboratory? Why can't we do the conventional laboratory testing? Why should we move on to an POCT, which is least sensitive sometimes? But as I know, the majority of the POC testing, what is available, it has got very good sensitivity and specificity also. And it should be user friendly. It should be minimal stuff. It may be just like our glucose random blood sugar. We should be able to do with a drop of a blood, and we should not be much complications. Taking a pipette, all those things, adding a reagents, all those stuff should not be there, and it should be a rapid and a robust one. Because now the majority of the laboratory system is automated. You can maybe within 30 to 45 minutes itself, you can get majority of your investigation in your from your centralized lab. But when you want a PSCT, it should be very rapid. Maybe the maximum affordable time maybe 5 minutes or 10 minutes. It all depends upon the test that you are doing. And it should be an equipment free, no complex equipment, and it should be delivered to the end users. It should not be a space occupying one. You need a huge setting to set up a POCT lab. So these all things will be an ideal to have a POCT in your department. So the next question that arises is why you need a POCT in ED. That is again when we started to implement our emergency department way back in 2008. So the administration, obviously they will ask why you need a POCT. We have the centralized lab. Why you want to invest again in this, and why you need it in the ED department? See, ED crowding is a global issue. So it is not just with India or just with the abroad. Anywhere you go, if it's a developed or a developing nation, ED overcrowding is a global issue. So only thing what we need to improve is the turnaround time. So we have an equipment that will give you a result within maybe 5 to 10 minutes as soon as the patient arrives. It will be a huge thing that the making the decision regarding the patient admission, where to admit the patient, whether we can discharge him, whether he definitely need to be in the ED or he need to go somewhere else. It enables a more rapid clinical decision making and diagnosis. Maybe in our ED, we almost have majority of our POCT testing. Maybe 15 to 30 minutes, we could have a basic provisional diagnosis. Which when we compare to the discharge diagnosis, it's almost 95% correct. So with the help of this POCT testing, we are able to run that. So ruling and rule out, you always know regarding the usefulness of D-dimer in a pulmonary embolism. And as a patient coming with acute onset breathlessness, we have got a D-dimer which is negative. We can easily roll out a pulmonary embolism. And again, deciding regarding treatment choices, especially when you have a testing like a CBC CRP on your hand and you have a procalcitonin also available with you, you can just briefly decide whether you are dealing with a very bad bacterial infection. It might not be an accurate investigation, but though still we will be able to give a clear-cut idea regarding where we are going. And especially for monitoring prognosis, we have to tell the family, okay, somebody is coming with a very bad metabolic acidosis, lactic acidosis. Okay, this is what we are going to expect from you. Maybe the family will be very much anxious to get an answer from the emergency physician. So again, the resource utilization, everything, you need a POCT without any doubt. You need a POCT device in the ED. So that will be my take on this. So what are the commonly done POCT in ED? As I told, early 1990s, maybe the first, much before that also. But to name it as a POCT devices, maybe 1990s will be the earliest literature that we will find it out. So it started with a fingertip glucose. Then your beta HCG, the standard urine pregnancy kits that came in. Now the most commonly used when you ask a POCT testing will be for acute coronary syndromes will be a troponins. So troponins has become just like you go to any majority main ED around the world, you will have a troponin point of care device available. Maybe CKC can be also will be there available, or a BNP also. So that will be the one of the most commonly used. And when you ask for POCT, the first thing that comes in our mind will be troponins. Now you will have acid-base analysis, your blood gas analysis, which you have a very good ABG analysis machine. You can get a reasonable good values of all your electrolytes also. That's all depends upon how you are sampling. Everything is there. Then, as I told, D-dimer for venous embolism. Then you have the sepsis markers. That is again one of the major chunk that that has helped us, because as being a tertiary care center, we will get a lot of sepsis cases being referred. So we have the markers like lactate. When you have a CBC CRP, you can go by with that. Also the neutrophil lymphocyte ratio, and maybe the procalcitonin also. And coming to the next important thing is the point of care INR. Whenever you have a patient who is on an anticoagulant, you need to decide on, he has come with an acute stroke. need to decide on whether you need to give thrombolytics or not. You send a lab INR, it is taking time. When you have a POC INR, maybe within another 3 to 4 minutes, you can make a goal of it. Again, in hemotoxic snake bite, way back in Kerala, what we have a lot of hemotoxic snake bite envenomation. So when you have POC INR, we can just frequently just check that instead of your standard bleeding time, clotting time, you can go with POC INR with the bedside itself, and we can decide of giving your anti-snake venom. So our protocol, we will be using a POC INR in snake bite victims. And toxicology, there are a couple of devices that has come for the drug screening. You have a patient who has come unconscious to you, you are not sure what is happening to him. You are thinking of a lot of metabolic reasons. Then suddenly you think that why it can be a drug overdose. But the problem is that you don't have a toxicology lab in your department. Maybe the toxicologist is on a holiday. So it will take another 2-3 days to get your result. We have a screening device. Next moment, maybe in the 15 to 20 minutes, you are getting the results. And again, in renal failure, you can have the creatinine and the NGAL. And there are a lot of influenza, HIV kit. These are all being done very frequently, but not influenza one is not very commonly done. But I think in abroad it's very common to have an influenza POC ones also. So that is the next session. Next thing what I need to cover: how much useful is to have a CBC CRP POCT in ED. See, there are a lot of article telling about CBC CRP to be done, but a POCT in ED, the articles are very evidence is very less. As I told, we are using since last 15 months, and what we are extremely happy with whatever we have been done. It has got amazing results. And turnaround time, again, that is one of the key factors. We are nearing 100 to 120 patients coming in a day, and majority of them are referred cases. As I told, being a tertiary care center, they all require, among 50% of those patients requires an ICU admission. So that is the statistics that we have. So for a tertiary care center like us to definitely have a POC, CBC, CRP, where we are going to have a maximum number of sepsis cases is very important. As I told, clinical decision making is much faster, and we have installed 2 devices. And before we taking up this device, we wanted to run a demo for nearly 200 samples and compared with our lab results. Without doing any testing, we cannot assure what exactly is happening. So this is the results that we got in. So accuracy comparison with HORIBA CBC CRP versus our lab CBC CRP, we approximately, as I told, nearing 200 samples. It is both pediatric as well as adult. And when we compared to our lab result, it was 96% accuracy for our total blood count, and hemoglobin was 95%, and little bit lower for the platelet count, maybe machine to machine variability, because as the platelet clump, the automated devices can give different results, but it was within the range. So there is nothing much more to be very panic when you see an 90% in platelet count, and CRP was nearing 94. As the device what we are having will not detect above 200 milligram per deciliter of CRP, so it will give an error value. So like that, it was around 94%. This is our experience with the HORIBA CBC CRP for the 200 samples prior to our installation. The rest we are just gathering the data. Now, what are the clinical usefulness of POCT CBC CRP in ER? As I told, starting with sepsis, you can start to know immediately the total count, whether it is a shift to left. Neutropenic sepsis, where again we have got an huge oncology group of patients coming to us. So again, to take a decision of neutropenic sepsis, neutrophil lymphocyte ratio, initiation of antibiotics, which is very key factor, which is one of the earliest bundle that we need to take care in an sepsis patient. And specific to COVID-19, maybe Dr. Dhruv will be exploring it more in his talk. And what we can do is, again, lymphopenia is one of the most common, and neutrophil lymphocyte ratio. In what mission we are having, we'll be able to do a granulocyte by lymphocyte ratio, because it is not a 5-part mission. So there is another 5-part mission which can give you neutrophil by lymphocyte ratio. And again, in dengue fever, maybe in another 2-3 weeks, because the rain has just started in Kerala, so we are just going to anticipate our number of dengue cases to slowly start rising. So platelet count, again, one of the major factor that decides upon the treatment plan, prognostication, admission plus or minus, all those things is very important to have an CBC CRP mission in the ED or in the fever clinic. Now coming to the next chunk of patients that we have is the GI bleeds. So GI bleeds, again, you need to prognosticate them. You need to decide on whether you need to give them transfusion, whether immediately you need to do them scopy or anything. You need to have a hemoglobin. That is the thing that that the gastroenterologist will come and ask, what is the hemoglobin? If it is above 8, he's happy to do a scopy then and there itself. If it is less than 8, okay, I will wait. So again, when you have a device in the department, we are getting it within 5 minutes, and the decision making is just like within a second we are going to take that. And again in trauma, definitely again with hemoglobin and hematocrit, as you know, the hematocrit increases the initial phase, and that shows the hemo concentration, so we need to pump in more fluids. So this perspective of CBC CRP is wonderful to have in a resuscitating our trauma patient. Then coming to the anemia evaluation, maybe as I told before, we have a lot of oncology patients, hematology patients coming in. So somebody suddenly comes up with generalized weakness, tiredness. We don't know what exactly happening. We are just checking with some pallor. We do a CBC CRP, the result is there, and then we can decide, okay, this guy needs admission and we need to evaluate him. And the next most important group of patient that we handle is the pediatrics age group. Again, the pediatrician, many of the time, they wanted to have an lab investigation to be done, basically to reveal anxiety of the parents. To be very correctly, the parents will be very much anxious when they bring in the child with fever, high grade fever. Whatever you say, they are not happy. So to have a device where you can give the result within 5 minutes and the parents are happy, the children are back home. So that is the next most usefulness what we have find. And the most importantly, consultants need not wait to get the result and then to decide. The results ready within 4 minutes. So that will be the most amazing thing regarding this point of care CBC CRP. So as I told, a brief thing regarding the neutrophil lymphocyte ratio. Again, one of the most important thing, as I told, but how will you calculate is just the absolute neutrophil divided by the absolute lymphocytes. That is how you can calculate. And a normal neutrophil lymphocyte ratio is roughly 1 to 3. An NLR of 6 to 9 suggests a mild stress, maybe an uncomplicated appendicitis. Above 9, it usually says that the patient is having a severe sepsis or a moderate stress. So we'll be able to do this with our point of care CBC CRP. And this is again the relationship between NLR and bacteremia in a heterogeneous patient population. Again, it's suggesting more to shift to left, more to shift to right, and all those stuff only. So now coming to the COVID-19, why you need a CBC CRP? I'm just intruding one slide into Dr. Dhruv's presentation. Due to the huge flow of inpatients in worldwide medical center, the physician needs a patient near solution. That's what we need. We need to make a decision then and there itself. A triage, how will we triage? Which group of patients? We can symptomatically triage them, but also depending upon the lab results, we can triage them. So how best we can utilize it in COVID-19 is basically you can quickly look for your lymphopenia. So the majority of the patients who are worsening, they can have a lymphopenia, and you can also go for their neutrophil lymphocyte or your granulocyte lymphocyte ratio. So that is the most important one to have a CBC CRP, especially in this COVID pandemic. So this is the HORIBA microsemi CRP device that we have installed in our department. It's a very small one, as you can see in the image. And this is the parameters that we can see in a total WBC, RBC count, hemoglobin, hematocrit, platelet, and the CRP. This will be a nutshell how we'll be seeing it in the device. And these are the parameters that we can get in through WBC, RBC, hemoglobin, hematocrit, platelet, lymphocyte, monocyte, and granulocyte, and CRP, and the calculated parameters like MCV, MCH, MCHC, RDW, etc. So that's really the outcome. Whatever devices we are using, these are the things that we used to get in from HORIBA. So as the utilities of microsemi CRP, you can have the pediatrics age group, post-surgery, gynecology, obstetrics, which we are not using. We are more concentrating onto the left side of the diagram that you can see the pediatric oncology, internal medicine, rheumatology, and the ICU. So that is how it's been being useful. So this is what is we installed in our department. You can just see how much space it has occupied. It is hardly barely maybe a desktop size. That's the maximum that it will occupy. So that is a device, and this is how the results comes in as a printout. And just to conclude, before that, we just wanted to see what are the advantages. Why you want this? How will you convince your admin team whether I wanted an CBC CRP device? Maybe you can convince your clinical lead, but to convince your medical administration is very difficult. Sometimes why you wanted the device? Maybe the lab income will be a different. Lab income will come down. Maybe the hematologist may be saying that is not accurate. But as whatever experience what we had, I can say the turnaround time, that's the one most important thing in a busy ED. To have a least turnaround time is the most priority. We need to take in a patient from outside. Even we have 50 beds emergency room, majority of the time it used to be full. Maybe due to the COVID pandemic, it's a slightly decreased, but prior to that, it was almost every day we used to have almost 95% of the beds were full. And again, in clinical decision making, it is very useful, and better patient monitoring, overall patient satisfaction. You can just see the patient is coming in. Within 10 minutes, you're telling him, this is your value and you're fine, and he's happy. So that is very important. And the bystander satisfaction, patient satisfaction, you can useful in many multiple clinical scenario, whatever I have described. And accuracy is not reasonable, it is good and it is excellent to our experience. And cost effectiveness, yes, it might be a little bit costly, but the amount of time that patient is spending in your department is very, very less. And the overall outcome, that is the patient care and the patient clinical decision making, is happening sooner. So it is definitely cost effective. And again, you can calculate the G by L ratio with the micro semi CRP what we are have. Maybe disadvantages analysis, maybe seeing the printout, what is this, whether is a what, I can't see the 5-part result what I see in the classic lab results. Maybe poor record keeping in the department. Maybe there is nobody, somebody needed to frequent audit that the people are ordering this, so that the income generation is not getting affected. Lack of results interpretation, as I told. Maybe an inappropriate testing which we hardly face, but for the sake of the completion I have to put some disadvantages, I'm adding it. Again, 5-part analysis is not possible with the device what we have right now. Whether we have another device which I think the HORIBA will be coming up to our institute. We are not very sure about it. And neutrophil lymphocyte addition. I think the next edition of the Pentax, you are planning for a neutrophil lymphocyte addition. N by L ratio will be calculated within the system itself. So to conclude, to have a POCT CBC CRP or any POC CRP is very much useful. There should not be any hesitation to start with this. Has become an integral part of an emergency department. There are two things that has rapidly changed the department. One is the ultrasound machine, that is a POCUS, point of ultrasound in the emergency room, and point of care testing in the emergency department. These are the two things which has to be there in any ED for a smooth running of the ED, to improve your patient satisfaction, to have a quick decision making, and to improve your turnaround time. And addition of N by L ratio, as I suggested. Accuracy, it is comparable to lab results. It is cost effective, most importantly, clinical decision making and turnaround time. So that will be my take on this. So thank you for your listening.
Thank you so much, Dr. Sri Krishnan.
Yeah.
I think we have been getting many, questions on this,
Okay.
which we can discuss after the sessions are completely
Sure.
over, and we can club it together, and then we can have a good discussion and let the people understand
Yeah.
on this part.
Yeah.
So with this, we are going to move to our second speaker of the day. The second speaker of the day is going to talk more so about his live experiences on the COVID patients. And I would like to introduce Dr. Dhruv Malhotra. He is an MD microbiologist and consultant microbiologist and an infection control officer at SLRH Hospital, which is an Fortis associate. He is a faculty for Infection Control Academy of India, editor and concept designer of Infection Control Trend, which is actually an e-newsletter which comes quarterly, diverted more towards infection control needs. He's also upgrading and a web designer, which is a very unusual for a doctor, but yes, a commendable one as for infectious diseases, which is a free online academic platform for the users, which was previously known as Microbes. And I think Dr. Dhruv can elaborate what is the new website has been called upon for our academic utility. And I would like to appreciate, and I would like to have a comment on the commendable thing which has been done by Dr. Dhruv. Recently also I had seen this going in our WhatsApp groups. He is mentored for Samadhan India, an innovation and research portal for new innovation in COVID-19 disease under the aegis of HRD, or the Human Resource Department Ministry, that is Government of India. So Dr. Dhruv, over to you. You can go ahead with your presentation. And yes, here you are.
Yeah, thank you for the introduction. And see, basically, I'm going to share the experience what we had since ever we begin with this COVID-19 thing in the hospital. So I'm going to share more of my experience related to the same. So as you all know, the presentation will be like a brief of the epidemiology, understanding the epidemiology, the case definitions, what are given by the government, the guidelines, including the both diagnostic as well as therapeutic, and some of the experience sharing, what we have been doing, and lastly, the question and answers, which will be combined. So as you all know that this SARS coronavirus, as you all can see here, has a viral factor which is like a shared with the bats coronavirus, and there are intermediate hosts. But for this particularly SARS coronavirus 2, we are not able to find out the actual intermediate host till now. But yes, it has a proper ACE2 receptor binding, which also is a route of entry for human cells as well. And you can see that there are some of the proteins, which are N protein, E protein, and different protein, which are actually the surface projections, and mainly is a S protein. So, and there are certain host related factors. So we all know that those people who are elderly, those people who have underlying diseases like the hypertension, then the chronic obstructive pulmonary disease, diabetes, cardiovascular diseases, they have the higher risk of getting the infection as well as the more severe form of the illnesses. And secondly, this disease is associated with the cytokine storm or sustained inflammatory response, hypoxia, and septic shock, etc., which are the complications, and severe complications like respiratory distress syndrome, metabolic acidosis, and even multi-organ failure is a very dreadful complication which may happen with this disease. So this is the epidemiology. And environment, as you all know, that environment, here we are stressing more on the environment also, because the transmissibility of the disease is through the contact as well as the droplet route. So that's why the environment also plays a very important role, because the survival, you can see that up to 9 days it can survive on the inanimate objects. So that is very important to know. If we go to the next slide, I will show you the, so that's why I stress upon the infection prevention and control part for the COVID-19. As you all know that these all bodysuits are seen everywhere in the news channel, everywhere in the reporters. And recently I get to see also the saloon owners, they are also wearing these kind of PPE suits and doing their duties. So, but the major basics is that follow the contact and droplet precaution, and airborne precautions are required when we are doing the aerosol generating procedures, mainly in the ICU and in the emergency department, where you are going to do these kind of procedure like intubation, suctioning, etc. So the type of PPE which is shown here is as per the CDC, where it consists of a gown, the face shield, the mask, and the mask also, if you are doing the aerosol generating procedure, then it is N95 mask. And if you are not in the ICU settings or other settings, it is a surgical mask with the face shield. So that is what is recommended for use as a PPE. Now, another important aspect which becomes important is the cleaning protocol. So here I have written about the environmental protocol as well as the principles. So environmental wise, one is the hand hygiene. So I think Semmelweis has taught us in the 17th, 18th century, and still we are not yet learning the art of the hand hygiene. So still we are learning basically with these kind of diseases. Follow the contact and droplet at all the times, at all the places. Then all cleaning, you use a sodium hypochlorite based compound or hydrogen peroxide based compound or soap and water, because this is the envelope virus. So your normal detergent and water is also going to be effective for these kind of viruses. Even for the linen management, you have to use a sodium hypochlorite, or you have to use a disposable or single use laundry. And for the food and beverages, you need to serve in only the disposable whatever items are there, the cutlery, all has to be disposable. And as far as the cleaning principle goes, so first here our idea is not ultra cleaning, But first, we have to inactivate the virus. Now, inactivation of the virus, so that's why the most important first step will be the fogging, okay, based upon the surface area of that room or that place in the hospital. Secondly, if you have a open hospitals, which are not air conditioning hospital, it is the best place, because then the natural light, natural ventilation facility, and the natural air changes will take place. If you have a closed air system, then at least 12 to 16 air changes are required to happen per hour. And for that, you have to allow at least 70 minutes of time, to replace the entire air of that room by the fresh air component of that room. So when you are doing some deep cleaning activity, at least this much time you require, so that the whole of the air of that room is completely replaced by the fresh air. Okay. Then another is a deep cleaning. So all deep cleaning you need to do some based upon the sodium hypochlorite compound. You can use a hydrogen peroxide based compound, and also you can otherwise check the US FDA guidelines, that whatever is a recommended, there's a huge list given of the compound which can be used for the environmental cleaning. That list can be used. Then another important part is the testing. So as we all know that initially it started with the foreign travelers which were returning from abroad. So within 14 days of their arrival, we were testing. Then after that, we shifted to all symptomatic patients who are like contact of these travelers. And then we went to the symptomatic healthcare workers, then the symptomatic people who are having SARI, that is severe acute respiratory illness kind of presentation. Then even all symptomatic healthcare workers who are in direct contact with the patient, we were testing initially. But now, as per the latest guidelines, we are only testing the symptomatic patients as well as healthcare workers. And as far as the asymptomatic goes, so certain disciplines, like those patients on the kidney dialysis, those with the pregnancy, then the chemotherapy patients, as well as lastly the surgical patients are also allowed to be tested for COVID-19. And the current testing protocol allows testing mostly for the symptomatic patients only. I think today evening we are going to again have one revision of the guidelines. Then the sample collection, so it is very important and the essential part. As you can see that there are two things which you can see. One is a nasopharyngeal swab collection, second is the throat swab collection. And you can see these kind of booths are made for the sample collection in most of the facilities. You can see in one of the places, you can see that there is a viral transport medium and there are two nylon flux swabs are there. And you can see that these nylon flux swabs are detachable. So you can just collect it and then put it in the VTM, and the terminal part, the tip, you can just throw it. And this is the schematic diagram, that the posterior pharyngeal wall should be swabbed, and it should be like a 3 times clockwise or anti-clockwise rotatory motion has to be performed while collecting the sample. As we all know that COVID-19 shedding is happening between 8 to 37 days with a median of 20 days as per the available knowledge. However, we all know that there are a lot of difficulties as far as the collection is concerned, the transportation is concerned, as well as the compliance to the government agencies, as well as reporting. And there is always inherent limitation of the test, because this test is a PCR-based test, which requires the ultra clean environment as far as the sample processing is concerned. If we go to the next, this is our experience with the PCR duration of the positivity in the symptomatic admitted patients in our hospital. So as you can see, around 20 patients, the RT-PCR tests were positive for less than 7 days. Most of the patient, that is 32 patients, the positivity was there for around 7 to 14 days, whereas only some patient like 8 and 2, this 10 patients showed positivity which may even lasted up to or more than 21 days also. So what is the significance of this? Why we need to study this? That because our initial discharge criteria, which depending upon the negative PCR results, and another drawback, of this test is, see, the dead virus is also shed in your nasopharynx and even the throat swab and whatever respiratory samples. So even this dead virus shedding is detected by this system. Secondly, the virus shedding is intermittent. So sometimes your patient sample will come positive, then it goes negative, then again it comes positive. This keeps on happening till around 14 days or 2 weeks. And around 30% of this test has a limitation of the false negativity with the RT-PCR. So this is another limitation which we have to understand. And as far as the antibody testing goes, I think we all know that antibody testing is not yet allowed for the diagnostic purpose in our country. So I will not comment anything on to that. So straight away I'll go to the another modality, that is the imaging. So as far as the CT scan goes, so, see, the findings are not very specific, okay? Because all the viral diseases will show these kind of findings, like the consolidation, the ground glass opacity. So, positive results are more accurate if the pre-test positive probability, that is, if you are suspecting that this will be more likely to be a COVID-19, then probably the as a diagnostic modality, it will come always as a second, because then when you know that yes, it is always like that, and then it will show this kind of picture. So all the radiologists differentiated COVID versus viral pneumonia with very high specificity but moderate sensitivity. So this is a very subjective bias which can happen with anybody who is diagnosing COVID-19 or only on the basis of imaging. Moreover, it is a radiologist gestalt and not the findings was used to diagnose COVID-19. So there is a lot of subjective variation. And another concern is the safety, because you are conducting radiological procedure or radiological diagnosis in the CT scan room of your hospital, or even for that matter, X-rays. So portable X-rays are preferred as compared to the proper X-ray room. And another thing is, suppose you are, because the CT scan machine requires the air conditioning. So once you are conducting the CT scan of these kind of COVID suspects or COVID diagnosed patients, then the air circulation you have to take care, because till the fresh air comes, then you cannot do the second scan. So this is one of the important things. And CT facilities are not widely available as far as our infrastructure goes in India. So, just to conclude the ACR recommendation, a normal CT does not mean a person does not have COVID infection. And an abnormal CT is not specific for the diagnosis. A normal CT should not dissuade a patient from being quarantined or provided a clinically indicated treatment when otherwise medically appropriate. So clearly locally constrained resources may be a factor in the decision making. So I think in our Indian context, I think at least what we are following is those who are developing hypoxia, that is less than 94% saturation in the pulse ox, only those patients we are conducting the CT scan examination. Now I think, can I have the video of the CT scan for this thing? So there is one CT
Yes,
scan.
yes. I'll just put it up.
Yes, yes. So please put on the video, because you can see the video. So you can see that this CT scan picture which we have taken from one of the patients. Okay, so just resume the presentation now.
Yeah.
Yeah, so I think the video you have already seen. So this is
Yeah,
the
it's
video is already played. I will not go. So now again, the next important topic which I'm going to open is like a Pandora's box, understanding the immune response to COVID-19. Because one of the things we all know that there is a cytokine storm, there's a hyperinflammation, and all these things are happening in this disease. And many of the things we don't know actually how they are happening, what is the internal mechanism. So I'm just trying to unravel the mystery of the immune response. So as after going through a lot of guidelines, I just found this one very concise snapshot of COVID-19. As you can look at this thing about it describes the clinical features, the life cycle of the virus, as well as very interesting facts on the immune response. I think it is not very clearly seen because the screen is very small, but I think it's available online, so you can just download and see that this uh, snapshot. Another important part which I wanted to highlight is this, because this virus has S, E, and M protein, and you can know that this ACE2 receptors act as a this portal of entry basically into the human cell, and then there is a fusion with the endosomal protease. Okay, so this protease carries out the fusion of this actually entire virus, and then the RNA is released into the cell basically. So and then this becomes an infected cell, and this infected cell is presented to the antigen presenting cell, that is your dendritic cell, and the tissue macrophages. So what was going to happen once this antigen is presented? There is a huge cascade of the cytokines and the pro-inflammatory markers basically, which causes there is an increase in the permeability, there is a fluid uh, is secreted. So basically, and then there is an this macrophages will try to engulf or contain this kind of a infected cell. So all these markers like neutrophil, the macrophages will increase, as well as the cytokines are increasing. But what is decreasing is that your T cell lineage. Everything, all types of T cells are going to decrease except for the naive T cell. And all these pro-inflammatory markers, you can see that interleukin 1 beta, GM-CSF, interleukin 6, interleukin 10, interferon gamma, then tumor necrosis factor alpha, interleukin 7, all are released. Now, as far as these, why we have to understand, because if you want to have a targeted therapy or immunomodulators, which any of them we want to use, then probably this will help us to understand the mechanism better, that what is working where, so here I have put also these things, this chloroquine, hydroxychloroquine, where all it is working, even the different drugs like anakinra, then I think tocilizumab is the most except mostly used basically in our settings. Also some trials are going on, and another are the JAK inhibitors, and many of these immunomodulators are under trial basically everywhere across the world. So this is the root cause, means how basically we are working on this. So some of the antiviral therapy are also very important, like lopinavir ritonavir combination and oseltamivir. And another thing is, today morning I read one paper from Hong Kong where they are having the trial of lopinavir ritonavir along with ribavirin. So these kind of antiviral cocktails also are being used, and they are showing some effects basically, but many of them are approved, some of them are under investigation, and some of them are still under trial. So it is all trial of these therapies is happening. Then another important drug is remdesivir, which is popular and which is discussed in many of the platforms, and that is another drug. So now we come to the clinical management guidelines. So as we all know that the government of India has already one guidelines on clinical spectrum of the COVID-19. So these guidelines basically divide the clinical spectrum, and the management is based on the what spectrum you are into. So these are asymptomatic patient, the mild pneumonia, the severe pneumonia, ARDS, sepsis and septic shock. So if the person lands in sepsis and septic shock, I think the blood culture and all this becomes a important investigation. So I will come to this part once we go on to the different. As far as the hospitalized patient goes, so here we have the Maharashtra state guidelines, which I'm going to discuss. So stage 1 is a mild early infection, which is divided into group A, B, C. Stage 2A is a moderate. case with the pulmonary involvement without hypoxia. 2B is a pulmonary with hypoxia, and stage 3 is a very severe kind of patient with systemic hyperinflammation with cytokine storm. That is a group A. So if E and F both are the ICU patients, and this A to D can be managed in the ward. So, as you all know, the treatment, so group A, hydroxychloroquine is the only drug given. Group B, it is combined with antibiotic and oseltamivir. Group C is basically Group B plus this CARP, that is a COVID awake repositioning protocol. You have left lateral recumbent, right lateral recumbent, upright and prone position in the bed, and basically you are giving the oxygen to the patient. Then the group D is a group C treatment. In additionally, you are giving the antibiotics, which are injectable antibiotics, and plus or minus, you are also going to give lopinavir ritonavir combination. And group E and F is ICU admissions. I think I will not discuss anything more on this because it's a very critical care management part. As far as the red flag signs goes, so it is the NL ratio. More than 3.5 is very important. Then P to F ratio less than 300, resting tachycardia, 3 to 4 minute exercise induced desaturation. I think this we have been able to find in some of our patients. Then raised CRP, ferritin, D dimer, LDL, triglyceride, troponin, CP can be. I think these all are the markers of the inflammation as well as the organ damage. And ECG, you have to monitor for the QT changes that may be related to the hydroxychloroquine therapy, or it may be due to the electrolyte disturbances, so that you have to continuously monitor. As far as the hyperinflammation goes, so I think one of the paper recently published from the Lancet told that the screening for hyperinflammation should be done for all the patients with COVID-19, and you have to use a H score. Basically, this H score is you monitor the temperature, you look for the organomegaly. I think this chart you can see it's very small. You can't see, but anyway, you can read this paper. It describes all the details. And another important is your CRP levels, the interleukin 6 level, D dimer level, LDH level, triglyceride levels, and PCT levels. So as far as this is a one paper, where I find how we can associate the discharge and death patient, what is the level of the hyperinflammation basically. So here you can see that this third column shows the C-reactive protein in the patients who got discharged and the C-reactive protein in the patients who were actually who died basically. So you know that those who are having mortality at much higher level of the pro-inflammatory this markers, and as otherwise you can see the level were much lower in those who are not those who are surviving basically and getting discharged. So another thing was the predictor of fatality from the recent retrospective. This is a Wuhan study which showed that the elevated ferritin, so the ferritin level were much higher in the patients who had actually uh, died, and in the non-survivor the level were much lower. And another, and it was p-value was very highly significant. Another is the interleukin 6 level. So I think some of these markers are very, very crucial, as far as the hyperinflammation in this patient goes. But and I'm going to share this our experience. So basically, mostly we are doing the CBC and the CRP levels as a preliminary for almost all the patients. So as far as our CRP level goes, so most of the cases we found that it was normal, basically around 36% of the patient, and high values of ranging from 6, because 5 is our cutoff value. So from 6 to 398, we found almost in 64% of the patient. But we all know that CRP is a non-specific marker of inflammation or infection. But as far as this COVID goes, I think it is certainly helpful because you got to know the as a prognostic marker also, because you can monitor the patients on this value. So I have done some of the cases I studied in detail where we had a serial values of the CRP, and this left side you can see is the one who had a mortality. Basically the patient died, and you can see the CRP values are very, very high in this patient, similar to the study which was found in the Wuhan. And as far as you go, that there is one insert happening on around 21st of April, that is a renal damage happening in this patient. Patient was having the has to be put on the dialysis because of the organ damage induced because he went into MODS. And another is a patient who showed the recovery. Even though the values are much lower for the CRP, you can see the maximum value was around 45, and he's continuously coming down. So immediate next day the value was just around 14, and again he showed rising trend, but his rising trend was because of the urinary tract infection. So this way we can use these markers for the prognosis of the patients as well. Even another thing which we study was the ferritin level. So inflammation in response to infection is normal, necessary, and protective. However, elevated levels not solely can determine the disproportionate or appropriateness of the inflammation. Beside inflammation, it is also released by the dying cells. So this we have to understand very much, and it is found mainly in severe patients like ARDS and may also indicate organ damage beside heart failure inflammation, or may be part of normal immune response to the virus, which we don't know as of now. So this we have to learn, means we will learn over the time, while dealing with this epidemic and pandemic. Then the ferritin level study. So basically all our clinical state 2B and 3 patients, basically those who are having hypoxia and those who required critical care support. So 14 patients had very high ferritin levels, and even in this patient, 6 had normal levels of ferritin. The value ranged from more than 40,000, because the 40,000 is the upper level of detection, to 289 as a lower limit. So median range was around 650 to 786, whereas the normal is just between 21 to 274. And if we look at the interleukin 6 study, so the values range from 10 to 2462. That is very high value, with a median of 31.61 picogram per ml, whereas our normal is just 0 to 7. So there's a wide variation in the values of interleukin 6. Now, interleukin 6, why it is important? Because our immunomodulator therapy, tocilizumab, probably is going to work in these kind of patients where you have this high level of interleukin 6. Probably those patients it is going to work. That's why it is very important to have these kind of prognostic markers. Another study which we did was in the fibrinogen levels in those critical patients. So 14 patients had abnormally very high values with a median range of 507 to 538, and normal is usually 200 to 400. So you can see that we have one patient with serial monitoring we did, and his values gradually come down over the time. And another was the D-dimer level. So we had studied, I think this is the very recent data which I just updated yesterday only, because in all this previously you can see 20 patients, here you are seeing 32 patients. So out of these 32, only 13 patients the values were normal, rest all were abnormal. So median range is around 2.4 to 2.58 d-dimer unit mg per, and the normal value is 0 to 0.35. So, and one of the patients where I had a serial monitoring of this, so I found that the over the week time it was a near one, and suddenly on the 8th, 9th, 10th the value became very high, So this is important. I mean, it may be of the clinical importance. So because the risk of thrombosis and everything increases with the high level. And another thing is the criteria for the ICU admission. So there's a need for the ventilation, need of the vasopressor, respiratory rate is high, saturation is low, there's a mental state disturbance, then the NL ratio more than 3.5, thrombocytopenia, uremia, multilobar infiltrates on CT basically, or in the chest X-ray. hypotension which requires resuscitation, and hypothermia. So these are some of the indications where you need ICU admission for this patient. And the discharge criteria for step down unit is when everything returns to normal, probably, where you don't require any supportive treatment. The heart rate is normal, the blood pressure is normal, respiratory rate is normal, patient do not have any neurological signs and symptoms. He can take the oral feeding and not require any other organ support. So that's when you can transfer the patient to the step down unit. And this is the latest discharge policy, basically, which has just come on the 9th of May by the government. So, mild cases, if they are asymptomatic, after 10 days of symptom onset, you can, and there is no fever for 3 days, then they can be discharged. There is no PCR required at the time before you discharge. In the moderate and the severe patient, so severe is already what we discussed. Then the moderate patient, if the fever resolves and the saturation is maintained without any support, then discharge after 10 days. Symptoms resolved and demand of oxygen therapy, if it continues, then discharge only after the resolution of all the clinical symptoms, and monitor the uh, oxygen saturation. If it is continuously normal for 3 days, then probably you can discharge. And there is no exit, that is no discharge, no RT-PCR test is required before the discharge. That is what is given by the guidelines. So if I tell the experience in a nutshell, so we had around 252 positive cases till 14th of May, around 50 beds we have dedicated to COVID-19, including the ICU beds, and it's a designated COVID hospital in the city of the Mumbai. So we started long back all the preparation from the March 2nd week, when we just first started the screening of all the staff and the visitors who are coming to the hospital with the thermal scanner. At the entrance, we closed all the gates of the entrance, and it remained only one entrance was kept open. Then the stocks of PPE, hand sanitizer, fogging machine, disinfectants, in the large quantity we tried to procure. Then the hospital preparedness for the operations and feasibility was conducted. Dedicated floor to stay and for housing the patient were designated. Even the staff were trained, the kitchen staff, the housekeeping staff, the nursing, the RMO, everybody got trained. Then the clinical protocols with whatever available guidelines, because initially we had only WHO guidelines. Afterwards, as and when the guidelines came, we kept on updating. Then we don't have a in-house PCR lab, so we liaised with the outsourced lab facility for the PCR test. And initially we had multiple labs to start with. Now we are streamlining with 1 or 2 labs, and the staff facilities like the food arrangement, the stay arrangement, the transportation, because of the lockdown. So all this we have done. Then the staff exposure and the contact tracing done as and when required, and unanticipated exposures, if you are working in a hospital, they are always going to happen. So, and now we are in an era where it is a part and parcel of life. Communication with the government authorities and the compliances as per the government as and when updated. Another important issue is I want to discuss is about the mortality. I think the mortality, the case fatality rate is 1.4 to 4.7%. It depends upon the population which is at risk, above 55 years of age, overcrowding, and other comorbidities. Today, as of now, if I consider the Indian data, it is around 3.2%. Looking at the positive rates of today, and also the deaths which has happened till today, because this is the latest figure which I've got. Comorbidities are like diabetes, hypertension, CKD, ISD. Then the unpredictable course of illness in positive patient, because every individual will respond differently to this virus, and usually those who present late in the illness and those with more comorbidities and elderly age has higher mortality as compared to the normal population. And it is suggested that the mortality might be due to virally driven hyperinflammation. So the same Wuhan study which I quoted previously, I'm going to quote again here, because this is what the study which associated this hyperinflammation along to the mortality. And what are the further learning lessons which we have? So complete cure and definitive treatment. When and how is a big question to all of us today. Vaccines are still under trials. The another important issue is those who recover have the restrictive lung disease with the fibrosis. Because those who undergo this cytokine storm, it is like a side effect of that, but whether it is temporary or permanent is yet questionable. Because usually the post ARDS fibrosis takes a year to recover, so probably it is too early to say that what is the course of this kind of restrictive lung disease. As of now, we don't know. Probably after a year or so, when this pandemic will be over, we will know much about this. Then another is the sequelae following the MODS and the supportive management. We don't know anything as of now. And another is about the reinfection and relapse. So there are predictions about second and subsequent waves in winter. So that is again a big question to all of us. So a lot needs to be learned in this area for research purpose, and only time will tell the tale of this COVID-19. As far as the concluding remark goes, I want to tell that still a lot more needs to be learned, explored, and experimented about COVID-19 as far as the agent, host, immune response, environment, as well as the treatment modalities which we have. Then we have to incorporate basic fundamental principles of infection control practices, starting with Semmelweis, because he was the first one to insist more on the hand hygiene. Still, we in the 21st century, we are still teaching people hand hygiene. So this is what is a big learning lesson which this pandemic is teaching us on hygiene, basically. And lastly, I want to tell that we have to learn to live and cope up with the available capacity for this COVID-19. So I think with this, I end. This is my clinical team and all my team members in the clinical team, and I would like to say thank you. And this is my mail address where you can address your queries or you can contact me. Thank you very much.
Thank you so much, Dr. Dhruv, for giving such an elaborative experience and a live experience of an Indian scenario, because we have been looking for Indian perspective and somebody sharing their experiences of the COVID infection and being there altogether. So I can also have Dr. Sri Krishnan on line now. So yes, we had done a good information, and I think both of you have were wonderful enough to share your experiences. And we also have overshooted a little bit of time, but still I think the audiences are there to so that we can take certain questions. So I think we will we can directly move on to I like very much specifically, because there are questions like why do we club CRP with the current situation or the current COVID infection or any other infections which are been there. So what is your thought process on this, Dr. Sri Krishnan? If we have a CBC CRP combination or a CBC CRP or a PCT combination or a CBC CRP IL combinations when we are dealing with some infectious disease or anything of that kind?
Hear me? Can you hear?
Yeah.
Yeah. Again, the CBC CRP combination, CBC CRP program, that's a big question, because previously when the procalcitonin came in, we were very much happy to have procalcitonin. When the procalcitonin was positive, okay, it is a GNB sepsis. We were very much interested to test the PCT. So like that, when the CRP came in, also we are very much interested to do that. But whenever you have a combination of 2 or 3 parameters coming together, we can get a better clinical idea. Then you will have the history in your hand, what will the patient presentation, and your clinical examination findings. With the help of CBC and CRP, with a very minimal time, we are able to get this. So that is the importance here. We can add on PCT, we can add on Ferritin, we can add a lot of things. But as an emergency perspective, when the patient is there, I want to take a decision immediately. So maybe I don't have much time to waste in the emergency department. So the rest investigations can come and we can add on to the initial CBC CRP. So the advantage is at the time.
Right. This question also goes to Dr. Dhruv. Dr. Dhruv, I just want to just tweak this question or modify this question. You had an experience of COVID patients along with all majority of the biomarkers being used, and the types of patient also like symptomatic or mildly symptomatic and severely. So can you comment on like a CBC CRP combination in a laboratory or in a clinic can become an initial screening tool for fevers, so that we have a classification of fever with a meta-analysis or the data which is there?
See, I think as far as this COVID epidemic goes, yes, I think it will be very helpful. But I'm not sure whether after this COVID, whether it will be still useful or not, because we have many other infections to deal in our Indian society, So that's why it will, yes, it will be of help now as well as afterwards, after this COVID era is over, probably also it will be helpful.
Right, because what I can see, I mean, this is for both of you. You can either of you can comment on this.
Yeah.
As a diagnostician, even myself, I still don't have an answer for a screening tool of an COVID suspected or a suspicious patient. And there have been questions like asymptomatic versus symptomatic. See, for me, asymptomatic meaning there is no symptom at all. So, are we looking for surveillance or a prevalence of that part? So that question is over. But if I have a patient of fever today, suppose it's one of the major symptom of any type of infection or an around, so a CBC CRP combination can at least give a little bit of an information, because there is no antigen available, there is no antibody screenings what we can do currently. And I think country like India, do you think RT-PCR would be affordable for a case of a fever?
See, I think so that CBC and CRP are very preliminary first line investigations, okay? And since
Yes,
we are in the COVID era, probably the pre-test possibility for CBC and CRP is very high, So as far as, because see, all this, see, CBC and CRP will not direct you towards anything, okay? They are just investigations which will tell you that there is an inflammatory process which is going on in your body or not, basically. And we live in a country where, even like all the types of sepsis, all the types of bacteremia and other infections also will have very high. Probably you have pneumonia because of streptococcal pneumonia that will also have a high CBC value as well as a high count in your CBC as well as high CRP level. So this will be like a very much individualized way you have to consider this, because as
right,
yeah, as far as this COVID is considered, till that time, yes, it is all right. But afterwards, we have to take it with a caution only, because every patient is different and their
right,
symptoms and their story is different. So, we have to
right.
deal with that thing.
So, Dr. Sri Krishnan
Yeah.
and Dr. Dhruv as well, would you like to have an fever clinic or an OPD in near future time?
Yeah, that is already we have it. We have been running it for the past 5 years in our
Okay,
hospital and dedicated fever clinic as such. So maybe in the COVID era, it has raised up the significance of it has increased. So definitely yes, we will have a fever. There is a fever clinic and there is an CBC CRP machine available adjacent to it.
okay. So, because there are many, I mean, there was like there were comments also on the chat, like it is a non CRP is non-specific. But what I see, because even I was in intensive care long time back, so we used to choose investigations in intensive care like inflammatory markers, infectious markers, hemodynamic markers, and coagulation. Basically, everything ends with coagulation. So the question
Yes.
here is, do we have to still say COVID-19 is an pneumonia situation or something else? Because there have been autopsy reported. Most of the patient died because of a DIC sort of a picture or a coagulo or a thrombosis, thrombotic event. So saying pneumonia is right, or because it is associated with lung, so it is pneumonia?
Saying just a pneumonia, I don't think it is right now, because when we didn't have enough data. Maybe the initial stage of maybe early March, we don't have enough data. After that, the cytokine storm started to rising. Then the Illy started doing with the cytosorb therapy also, and they had some favorable outcome with cytokine storm. Then the tocilizumab came in. Then the DIC, the role of the heparin, all those things came in. So definitely, it is not a pneumonia. We can call it as an COVID disease. That disease itself, it is not just pneumonia. It is just like a multi-organ dysfunction syndrome,
Right,
what we see. Maybe the
right.
H1N1, what we had, maybe in the
Yeah,
2010,
exactly.
2011, was a totally a different scenario, and we were happy to treat, and we overcome it very quickly. We never had this much fear about H1N1. But what
Right.
COVID-19 has done, it has gone into this multi-organ dysfunction, the cytokine storm, and all those things. That is creating more of an issue rather than the pneumonia just alone.
Right. So, Dr. Dhruv, I have a question from this set only, but I have been placing it up because I really had my doubts on discharge policies. Because, so do you think clinical remission or the clinical symptom free of a patient is enough to discharge for isolation?
See, what I think, see, currently what is the situation in the country, you have to understand that our medical capacity to deal with the population which we have, we don't have enough of the things, So that's why these guidelines are updated as per the preparedness, as considering the multiple strategies which the government is trying to figure out. Because see, now we have started showing a very high number of cases, okay? And if we
Right.
start admitting even all the patients, probably we don't have that much because in what is happening, the beds are occupied by the asymptomatic patients, and actually those patients who require the treatment, those who are having hypoxia, those who are having the respiratory distress, they are not having the availability of the bed. Even this COVID thing is actually crashing our existing healthcare system because those patients who are having fever, which is a not COVID type, they are suffering because they are not finding any bed in the hospital to get admitted or treated, So these and another thing is about the testing. See, we are a resource towards setting. We don't. We have to reserve our treatment facilities for actual time when we need those. Now, just to have a discharge time RT-PCR, I want to tell you that you may be shedding a dead virus, okay, which is not going to cause anybody infection, but still you are positive on RT-PCR. So definitely it is not going to harm anybody, but still you are positive, so you cannot be discharged. So think about this perspective,
Right.
and this is very essential and crucial for the country like India when we talk about this kind of diseases, which is a pandemic, and
Right. Right.
we have billions of people in our country. So probably we
Right.
should be very much judicial in our as far as the
Resource.
resource allocation goes, for the country.
Exactly. So with this same thing, I would like to have your comment on, like, you had experience of COVID patient. So even to Dr. Sri Krishnan, he may take up the same question.
Yeah.
What is your frequency of testing with these patients? I mean, if you're doing a baseline investigation like CRP or an IL-6 or a D-dimer, how do you decide on the frequency of testing? Because you had shown a beautiful chart of stage 1, stage 2, stage 3. So mild, moderate, and severe, if we just say it. So if I have a mildly symptomatic patient, so what should be my frequency of testing?
No, mild we are not testing. We are only testing only those patients who are having hypoxia,
Right.
basically with the pulmonary involvement, and only those patients who are critical in the ICU admission.
Okay.
Those
Okay.
patients we are doing the testing, not frequently to all patients. Probably
And
only commonly done investigation in normal patient is a CBC and the CRP value initially, okay, as a primary investigation.
right.
But
Right.
these all investigations are done only when there is a hypoxia component, there is a multi-tubal infiltrate on the CT finding or on the
Right.
X-ray, and when the patient is critically ill and showing all the features of hyperinflammation or the cytokine storm or ARDS, and only in
Okay.
those cases we are doing this
So,
investigation.
Dr. Srikrishnan, what should
Yeah.
be the frequency of testing? This is what important is when we
S-
monitor a patient.
Yeah, see, again for COVID-19, for luckily till day, I had never had any experience of managing a patient because in our hospital in Kerala, as such, we had just 550 cases as of now, and
Right,
and our government were so happy to retain them in their government hospital. The private sector was never involved. So as such, prior to this COVID, or we had the experience with H1N1 or whatever sepsis we usually admit in our ICU. So what usually, as Dr. Dhruv
right,
suggested, maybe the when they are critically ill, when they are in the ICU, maybe a daily analysis for the maybe the initial till we know the patient status, how the patient is doing about. Maybe the first 3 days we'll be doing a continuous analysis. Once they are out, once in 2 or 3 days, depending upon the clinical features. If there is any clinical feature worsening, we would like to have this investigation. As such, we don't have a definitive say like every second day we need to do the CBC CRP.
Right,
Every day
right.
we will be reviewing it and we'll taking a call on it.
I think we had, I mean, covered majority of the areas, right from the emergency department to the laboratory services, catering to the department, point of care testing, the utility of a very simple baseline investigation like CBC CRP may be a game changer sometime, and maybe it gives you an. See, for me as a pathologist, I am always happy when there is a high sensitivity of any of the screening type of an investigation, right? And I think we have overshooted the time, but yes, audiences are kind enough to stay back and listen to the conversation. So with this, I would like to thank both of you as a
Thank you.
speaker, taking out of your time from your busy schedule. And you both cater to the clinical fraternity. We here are diagnosticians, and the people who joined were from the hospitals and the corporate hospitals, government hospitals. I could see the head of the department also joining and listening to the entire webinar. So I am really thankful to both of you, Dr. Sri Krishnan and Dr. Dhruv, for taking out of your time, throwing light on how an emergency department should be operable in this pandemic situation and in the routine cases wherever we are having, right from going from a mild case to a severe cases. So thank you so much, and thank you so much to the audience as well to be there. And you can very well give up your feedback and the questionnaire if you have any for both of the speakers of the day at hematology.hin@horiba.com. Thank you so much. And with this pandemic situation, which is going a little bit easier nowadays, the lockdown may ease after 17th of May. Let's see and hope for the best. And you can just write down whatever your experiences are to us so that we understand this disease more rather than we rely more on Chinese articles or say European or the American articles. So with this, I would like to take off your leave from the audiences and you. Thank you. Thank you, all the audiences. And this is your host, Dr. Prakash from HORIBA Medical. Thanking you all, and stay safe, stay healthy, and just take care of yourselves and your loved ones. Thank you, and Jai Hind. Thank you so much.
Thank you.
Thank you.